Yeah. So, a very pleasant evening to all those delegates who have logged in for today's evening webinar sponsored by Novo Nordisk. And thank you, Sujay and Saurav, for organizing this webinar and giving me opportunity to speak on a very relevant topic of total control with insulin co-formulation, a patient-centric approach. We all know that there are several conundrums of diabetes management. Diabetes being a very rather pathogenetically and by its complication a very complex disease, and its management is also likewise very complex. And in the life of a type 2 or type 1 diabetes mellitus patients, a time comes then we have to think of a proper planning to manage the several issues related with this disease. So we shall be discussing all this, and our today's talk is structured in three parts. In the first part, we shall be discussing the various issues involved in the diabetes management, and in the second part, we shall be discussing how best we can address or rather control the diabetes mellitus with two-in-one co-formulation of insulin degludec and insulin spart. And then we shall be discussing the practical dosing recommendations in this for these formulations. So let us begin with a index case study. This is a accountant by profession, type 2 diabetes mellitus since 10 years, and systemic hypertension since last 3 years, dyslipidemia since last 3 years. And the current medication says on that metformin she is taking 1 gram BD, glimepiride 1 milligram BD, empagliflozin 25 milligram OD, telmisartan 40 milligram OD, atorvastatin 40 milligram OD. So, and investigations done about 1 month back shows that fasting plasma glucose was 172 milligram per deciliter, postprandial plasma glucose was 242 milligram per deciliter, and glycated hemoglobin was 9.1%. So you can see that the her glycemic status was not well controlled, and she was not on the target. And even on subsequent follow-up, the postprandial glucose shows a rising trend. So the question comes to our mind: how best we can manage such a case? And we all know that we have many challenges in the management of a diabetes mellitus case. We know that we have in most of our patients, we have a very poor glycemic control. But recent data shows that 76.7% of adults with type 2 diabetes mellitus in India fail to achieve glycated hemoglobin target of less than 7%. And likewise, there is poor postprandial glucose control also, and this is evidenced by the fact that only 83% of adults with type 2 diabetes mellitus in India have suboptimal postprandial glucose control. And we all are aware of this therapeutic inertia, and we know that only 10% of adults with type 2 diabetes mellitus in India received an injectable treatment after 10 years. So this is quite a disheartening fact that even after the lapse of 10 years, injectable preparations were not introduced in the management of diabetes mellitus. And this led to the person being in the out of range glycemia for pretty so long a time, inviting the dreaded complications of diabetes mellitus. Then there is a question of adherence to diet, and we have data that shows that only 38% of total diabetes mellitus participants adhere to a diet. So this is also a sad fact. And hypoglycemia complicates so many cases, and people with type 2 diabetes mellitus in Southeast Asia have an estimated 3.4 severe and 14.6 non-severe hypoglycemia events per year. So each hypoglycemia events discourage the healthcare providers as well the patients also for this treatment, and hence this adherence and compliance is rather worsened in those cases. So control of postprandial glucose excursions may be an unmet need of diabetes management in Asian population. As you can see on the left side panel, you can see that in the insulin naive patients, you can see this blue bar shows the Asian data, and green bar showing the non-Asian data. This breakfast, lunch, and evening meals, this postprandial glucose increment shows that this blue bar is showing in Asian population quite more, showing this increment of postprandial glucose. And in insulin experience cases, as you can see, this is rather less pronounced, and the right half of the panel shows this. And evidence from our most Indian studies shows that there is most of our patients is having high postprandial glucose, and subsequently high glycated hemoglobin also. So uncontrolled glycemia in India demands timely treatment, optimization, and insulin therapy. This has been evidenced by so many our own Indian studies like IDCI, DiabCare, A1 Chief Present and Improve study, in which you can see that this is glycated hemoglobin ranging from 8.59 to 9.3, and likewise fasting plasma glucose and post plasma glucose showing a increased trend. So we also know that our Indian reality is that we consume a very high carbohydrate diet. Our dietary habit is such that 61 to 70% of energy intake in Indian is through carbohydrate present in the diet. So this high carbohydrate diet leads to a raised postprandial glucose level, and this study carried out by the India Diabetes Care Index, in which there were 350,000 participants whose mean age was 55.2 plus minus 11.9. Glycated hemoglobin was 8.56 plus minus 1.8, with fasting plasma glucose 172.2 plus minus 61.9, and postprandial plasma glucose showing 253.6 plus minus 92.1. So this was the profile in this India Diabetes Care Index study, and it showed that more than 83% of the patient had postprandial glucose more than 160 milligram per deciliter. And this in the management of type 2 diabetes mellitus, we employ several oral anti-diabetic drugs for the management of this glycemia, but sometimes we can only this OAD inadequacy has the lessening effect on this this glycemia control, and a clinical situation comes where glycated hemoglobin remains above goal despite concurrent use of optimal dose of 3 oral glucose lowering drugs of different classes, one of which should be metformin, and the second preferably a sulfonylurea, provided adequate diet and exercise has been followed and comorbid condition causing hyperglycemia was ruled out. So this is the criteria that is required to label a case as OAD inadequacy. So the patient must be given one of the drugs should be metformin, the second drug should be sulfonylurea, and adequate diet and exercise management should be instituted in those individuals. Only then, if our patients are not up to the target, then we can label the patient as OAD inadequacy. And on the left side, you can see that the addition of a fourth OAD does not provide substantial lowering of glycated hemoglobin. So going on adding one after another oral anti-diabetic drug is not going to help the patient much. So as sometimes even addition of the further oral anti-diabetic drug rather deteriorates the condition so far as glycemic control is concerned. So the indices for holistic choice of insulin therapy, the need of an insulin therapy that offers control. We should have an insulin that offers lower hypoglycemia, that offers meal-time flexibility, that offers simple regimen, that offers convenience of device, and offers better quality of life, and of course cost effectiveness is also prime requisite also. So effective glycemia requires the control of fasting plasma glucose, postprandial glucose, and glycated hemoglobin also. And in this regard, insulin degaspart is a prudent choice. We shall be seeing in the next slides. Insulin degaspart is the world's only co-formulation insulin, and it is a combination of 70-30 combination of ultra long acting degludec 70% and short acting aspart 30%. And in this co-formulation, in one single solution, these two components exist. This insulin degludec exists as dihexamers, and insulin aspart exists as hexamers, and the two insulin components do not interact in the solution and in the subcutaneous tissue, thereby retaining their individual properties. So this is the beauty of this formulation. And this is a combination of quick release prandial insulin with slow release basal insulin. As we know that this prandial aspart component is rapidly absorbed, and it has a faster onset of action, and its duration of action is also very short. So glucose lowering effect is immediately instituted, and we can take care of this postprandial glucose surge by this insulin aspart component in this co-formulation. And the main 70% of the constituent of this co-formulation is the basal insulin degludec component. It gives a flat and a stable steady state, and insulin monomers slowly and gradually dissociates. And you can see this graphical representation, this co-formulation insulin degludec and aspart combination. And after the injection into the subcutaneous tissue, the phenol diffuses quickly, and insulin degludec dihexamers link up via a single side chain contact to form long multi-hexamers. And this insulin aspart component monomers are released into the circulation rapidly, and this takes care of the glucose surge that is affected with the taking of the meal. And zinc diffuses slowly, causing the individual insulin degludec hexamers to disassemble and releasing monomers very, very slowly. So this takes care of this 24 hours steady state, and this graph also beautifully represents that fact that this aspart portion, mealtime control with insulin aspart is shown, and there is a flat and a stable control with insulin degludec. So both these components takes these two events, that is postprandial glucose surge and 24-hour basal steady state control. So ideal patient profiles for this insulin degaspart initiation should be those patients who are not controlled on oral anti-diabetic drugs, and of course there is need for safety and flexibility at initiation. And also we can also start these co-formulations on those patients who are uncontrolled on basal insulins, because and this also provides the need of this ease of flexibility, and the unacceptable weight gain with other basal insulins are not with this co-formulation, and of course the unacceptable hypoglycemia evidence with other insulin regimens are not there with the use of this co-formulations. And need for safety, especially in the elderly and frail individuals, we are very much concerned about this safety issue, because there is hepatic impairment, renal impairment, and fasting condition, and erratic meal patterns. These all are our safety concerns, which is well addressed by this use of this co-formulations. And those patients who are already on premixed insulin, either OD or BID doses, or with basal plus insulin regimen, in which there is poor fasting glucose control, they are also a subject of this co-formulation institution. And of course they need flexibility in treatment also, and recurrent hypoglycemia can be avoided with the use of this co-formulation. And those patients who were on basal bolus insulin regimen, and their they were having this unacceptable variability. In those cases also co-formulation offers a better rather glycemic control. Then recurrent hypoglycemia is an issue with other basal bolus regimens, and this co-formulation provides rather some relief in those individuals. And of course flexibility is well addressed. So this is going by the study reports. This is a study report showing this insulin degludec OD along with either with or without this oral anti-diabetic drug. And these all patients were insulin naive patients, and sample size was 296. 147 persons were put on insulin degaspart OD along with this oral anti-diabetic with or without. And in another 149 subjects, insulin glargine 100 units was given OD along with or without this oral anti-diabetic drug. The study duration was 26 weeks, and there was a significantly better postprandial glucose control after the measure meal, and about 57 milligram per deciliter of this postprandial glucose reduction was evidenced with the use of this co-formulation, and hence it offered a superior glycated hemoglobin reduction to the tune of 1.4%. So insulin degaspart provided superior long-term glycemic control compared to insulin glargine 100 units with lower risk of hypoglycemia. And a similar control of fasting plasma glucose was seen with basal component also, like 70%. And insulin degaspart 72% with the use of this co-formulation, 72% more patients achieve their targets without experiencing hypoglycemia than OD insulin glargine U100. So this is quite significant finding from this study. In another study, you can see the adult patients with type 2 diabetes mellitus who were uncontrolled on oral anti-diabetic drugs, and some 89 individuals were participated received this insulin degaspart, and about 120 patients received this insulin glargine. And the percentage change in the glycemic parameters, you can see this blue bar showing this insulin glargine and green bar showing this insulin degaspart, and you can see that this degaspart affects a greater reduction in the percentage change of this fasting and postprandial glucose. So insulin degaspart provides significantly greater glycemic reduction in glycated hemoglobin, fasting plasma glucose and postprandial glucose versus insulin glargine U100 along with similar safety profiles. So these were the study conclusions. And time to treatment intensification seen in this co-formulation versus insulin glargine U100. And the time between index date, that is date on which glycated hemoglobin more than 7% on existing therapy was shown, and the first prescription of additional anti-hyperglycemic agent and dose intensification during follow-up period was done. And there was significantly fewer subjects on insulin degaspart required dose intensification, and additionally the time to treatment intensification was significantly longer in subjects on insulin degaspart as compared to insulin glargine. And we have real world evidence also showing that switching to degaspart from glargine U100 or 300, there was a significant reduction in basal and total daily insulin dose with insulin degaspart after 26 weeks. And regarding the quality of diabetes therapy related quality of life, there was significant improvement in total diabetes therapy related quality of life score with insulin degaspart in patients with glycated hemoglobin more than 7%. And treatment preference, it was shown that 74.2% preferred insulin degaspart to their previous treatment. So switching to insulin degaspart is associated with a lower total and basal insulin dose requirement and significant improvement in quality of life. And Impact on quality of life and treatment preferences. Another study shows that 94.2% manage their day-to-day activities better after insulin degaspart initiation, and 89.8% had improved quality of life with reduction in number of pricks, and 86.7% found it comfortable to inject insulin degaspart in different social situations. So this is very also important, because most of times diabetic individual taking insulin find it uncomfortable or rather embarrassing to take insulin in some social occasions. But with this co-formulation offered them convenience. A reduction in number of injection pricks, flexibility and simplicity of dosing with insulin degaspart translates into better quality of life. And regarding the pill burden, this reduction in pill burden with insulin degaspart initiation was shown that 70% of patients on 3 oral anti-diabetic drugs could be shifted to 1 or 2 oral anti-diabetic drugs, and 50% on 2 oral anti-diabetic drugs a day were shifted to 1 oral anti-diabetic a day. So definitely it reduced the pill burden. And reduction in pill burden with insulin degaspart initiation, you can see this horizontal bar showing this effect, and percentage of individuals with lower pill burden is shown there. So reduced pill burden improves quality of life and adherence to treatment in individuals with diabetes. Cost effectiveness when calculated with the use of this co-formulation, yearly total cost of medications and healthcare resources based on Indian cohort in which these factors were taken into consideration, like this outpatient visits, emergency room visits, inpatient hospitalization, work days missed, and it showed that yearly total cost including that of medication and healthcare resource use was lower with insulin degaspart as compared to all treatment by rupees 2,955.83. The number needed to treat to bring one patient to targets of glycated hemoglobin less than 7% and less than a predefined individual treatment target was lower with insulin degaspart. So insulin degaspart is cost-effective treatment for people with type 2 diabetes and not achieving glycemic targets on other therapies in routine clinical practice. So practical considerations regarding this use of this co-formulation we shall be discussing in this part of our discussion. And dose at initiation, dose mealtime relation, titration, intensification, co-administration with other anti-diabetic drugs, and choice of devices. We shall be focusing on these issues. And we all know that this is administered with the largest meal of the day, and it is initiated with 10 units to start with insulin degaspart OD, and it is administered at any measured meal, whichever your measured meal is, either breakfast or lunch or your dinner. At that time this insulin co-formulation is taken, and this degaspart OD with the most carbohydrate heavy meal of the day should be taken, and can be given with different meals on different days. So this is also very convenience, gives a convenience to our patients, that it can be taken with different meals on different days. One day if your breakfast is heavier, you can take at the breakfast. In another day, if your lunch is heavier, you can take at the lunch time. So this is quite a convenient situation with the use of this co-formulation. And this insulin degaspart BID can be used with the 2 most carbohydrate heavy meals of the day, and meal size and postprandial glucose response should dictate the ratio of the 2 doses. And if we use this co-formulation in BID dosage, then the ratio of this dosing should be decided by the meal sizes, and it doesn't have to be a 1:1 split. So it need not be the equal proportion at both the meals. And if the meal is breakfast meal is larger, then we can take a larger units of this co-formulation at breakfast and rather than at lunch or dinner. So this is quite convenience. And practical recommendations for starting this and starting or rather titrating this co-formulation is that we should take fasting plasma glucose as the value based on which we can titrate, either up titrate or down titrate. If our fasting plasma glucose, if our value is above the fasting plasma glucose, then we can increase by 2 units. If it is at the fasting plasma glucose is at target, we must maintain that dose, and if it is below fasting plasma glucose target, then we should reduce the dose by 2 units. And insulin degaspart OD should be used at the measure meal, and fasting plasma glucose should be taken for titration. And in case of BID dose, either pre-breakfast or pre-lunch or pre-dinner can be taken, or pre-dinner values should be taken as for titration. Likewise, if we use pre-dinner, then pre-breakfast dose value shall be taken for this titration. And intensification with co-formulation is also very easily achieved, and it can be used either in OD or BID doses if we have to intensify the treatment. Other insulin regimens can be shifted to insulin, this co-formulation, and co-administration with other anti-diabetic medications are also very easily achieved with the use of this co-formulation. And when to intensify? If there is a postprandial glucose excursion after 2 meals in 2 weeks, then, and if these excursions are unresponsive to dietary manipulation alone, then we can up titrate our dose of this insulin degaspart, and we can switch over to this BID doses. And OD dose should be shifted to BID doses whenever there is a requirement of more than 30-40 units of this formulation. And how to intensify? Total daily dose can be split over 2 meals with greatest carbohydrate content, and as already talked earlier, ratio based on relative carbohydrate content and postprandial glucose excursions. So the dosing of these 2 doses can be decided on the relative size of the meals and their glucose content. So switching to insulin degaspart from other insulin regimens is also very convenient, and basal or premix OD dose can be shifted to insulin degaspart OD or BID. Basal or premix BID can be shifted to insulin degaspart BID or OD, and basal plus bolus regimen can be shifted to this insulin degaspart formulation, and the treatment can be individualized as required. So switching needs to be individualized and based on careful consideration of basal bolus dosages, and close blood glucose monitoring of course is required to this up titrate or down titrate the dose. And co-administration of degaspart with other anti-diabetic agents are well tolerated, and insulin degaspart can be used in combination with most oral anti-diabetic drug, and concomitant use with SGLT2 inhibitors and SGLT2 inhibitors along with co-formulation initiated subsequently. The dose should be titrated weekly to reduce the risk of side effects. And concomitant use with sulfonylurea, if this co-formulation of degaspart is used in BID doses, then the sulfonylurea should be discontinued. And if this degaspart administered in OD dose, then we must reduce the dose of either reduce the dose or discontinue the use of sulfonylurea. And concomitant use with GLP-1 receptor agonist, adding a degaspart to a GLP-1 receptor agonist in initial daily dose of 10 units is recommended, and adding GLP-1 receptor agonist to insulin degaspart, the insulin dose may need to be decreased based on glycated hemoglobin. And there is no additional consideration when combining insulin degaspart with metformin, alpha glucosidase inhibitor, or peptidase 4 DPP4 inhibitors. So this offers a convenience with the use of other medications. And so far as the devices to deliver this co-formulations are concerned, we have convenient devices. in the form of Flex Touch and NovoPen 4. Flex Touch is a disposable insulin pen which has a very rather beneficial property like no push button extension, unique injection mechanism, very low dose force required, and end of dose click is also there, and accurate and consistent dosing is achieved with the use of this flex pen device. And if we want to use a stable and durable insulin pen device along with the cartridges available of this co-formulation, then we can use it with NovoPen 4. And it provides accurate dose delivery for more than 5 years, and low dose force is required to inject, and there is easy dose adjustment also, and easy to read dose scale. Dose scale is printing is quite rather significant sizes, so it can be seen with the elderly individuals also, and it is quick and simple to use. So both this Flex Touch and NovoPen 4 offers convenience in delivering this co-formulation and for the use in our patients. And this co-formulation we have seen, going by its merits, we have all seen its convenience of use, its up-titration, and its rather compatibility to use along with other groups of anti-diabetic medications. This is a prudent choice for Indian scenario, as it is involved with lower hypoglycemia. It provides mealtime flexibility. It is a very simple regimen to use, and there is convenience of device in the form of Flex Touch and NovoPen 4, and it also offers a better quality of life, and we have seen the calculations regarding the cost effectiveness also. So it offers cost convenience also, and it is better. It affects this glycemic control in a better way, as it reduces postprandial glucose, fasting plasma glucose, and glycated hemoglobin. So far as safety, convenience, simplicity, efficacy, flexibility, and quality of life is concerned, in this formulation of insulin, degludec and aspart offers a wonderful solution for the treatment needs of our type 2 diabetes mellitus patients. And accordingly, Mrs. Subha, the next case that we discussed, she was put on this treatment, and there was optimal efficacy and safety at initiation. Insulin therapy fits into the lifestyle of this patient, and it offered flexibility, offered convenience, better quality of life, and cost effectiveness. So this co-formulation is better suited in our those patients of diabetes mellitus in which we have seen that use of several oral anti-diabetic drug have failed, and we have documented the oral anti-diabetic drug inadequacy as defined earlier, and in those cases use of this co-formulation provides better glycemic control and brings most of our patients to target. Thank you very much for giving me a patient.